Hello, my name is Tim Turnham. I'm the Executive Director of the Melanoma Research Foundation. Thank you for joining us on this webinar in which we'll spend the next hour talking about the way treatment for melanoma is changing, the different treatment options that are available for patients, and how best to manage your treatment for melanoma. We're joined today by an expert panel of people who are at the top of the field of dealing with melanoma, and you'll be hearing a lot from them about these different treatment options and these various ways of dealing with your cancer. Just a word about cancer. Cancer begins as normal cells that begins to do abnormal things. If you have a cut on your arm or on your hand, the body tells the skin cells to grow and divide and heal that cut. But those cells should not be growing and dividing without that signal. Cancer cells somehow have learned to grow and divide without being told to, and they don't stop when they should. That's because of some changes that happen deep inside the cells. And we'll hear about therapies that go into those changes and shut them off and help close down the cancer. Also, in a normal situation, when cells get out of control, the body has ways of dealing with those cells called the immune system. This is the same system that helps us fight off infection or a virus. And it should also attack these cells when they begin acting abnormally, but cancer finds a way of hiding from the immune system. We hear about the immune system getting re-engaged in cancer in drugs that are called immunotherapy drugs that help this to happen. So you'll hear some of these terms, but our doctors will explain them carefully. And I think what you'll hear is that this is an exciting time, but also a time when we need to make very good decisions. As I said, we're joined today by an outstanding panel. I'd like to take a minute to have each of them introduce themselves to you. We'll begin with you, Dr. Schuchter.
Good morning. My name is Dr. Lynn Schuchter. I'm Chief of Hematology Oncology at the Abramson Cancer Center at the University of Pennsylvania, and I'm delighted to be here today.
And I'm Dr. Michael Atkins. I am Deputy Director of the Georgetown-Lombardi Comprehensive Cancer Center in Washington, D.C.
Good morning. I'm Dr. Anna Pavlick. I am the director of the NYU Melanoma program and also the director of their clinical trials program.
So we're very privileged to have this team with us. They represent having treated thousands and thousands of cases, and will have wonderful information for all of us. Just a word about the webinar. In the course of the next hour, you'll have some questions pop up on your screen. Take a minute and answer those questions. We will learn more about our audience and how we can answer better the questions that patients have in the future. Also, you'll have the opportunity to ask your own questions, and we have carved out a bit of time at the end of the webinar to address those questions. A number of you, when you registered for the webinar, submitted questions. We have those ready to answer, but we welcome your questions live as well. So we'll begin, Dr. Schuchter, with you, and I'd like if you would take a minute to help us understand the landscape of melanoma. What is melanoma? What should patients know in order to go into their treatment of this cancer?
Thanks, Tim. Today, the seminar webinar is going to focus on patients with advanced melanoma. So we did think it would be important to explain the different stages of melanoma and start with a broad overview of the different approaches to treatment. So melanoma, as you said, is a type of skin cancer. And there are 4 stages. Stage 1 and stage 2 melanoma involves melanoma that's confined to the skin. And the difference between stage 1 and stage 2 depends upon the thickness of the melanoma and some other features. Stage 3 melanoma is if melanoma has traveled to the lymph node, so that we call this regional disease. So if a melanoma was on somebody's arm, regional lymph nodes would be underneath the armpit. So traveling to regional lymph nodes is considered stage 3 melanoma. And patients with stage 4 melanoma or advanced melanoma is melanoma that has traveled through the bloodstream and traveled to distant sites. Today, we're going to focus a lot of our discussion on management of patients with advanced melanoma, treatment of patients with disease. But it's a very important concept to understand. For patients with earlier stages of disease, we treat mainly with surgery, and everyone should understand that early stage melanoma can be very, very curable. Patients that have melanoma that travels to lymph nodes is also curable melanoma and requires surgery. We often give additional therapy. We call this adjunctive therapy or adjuvant therapy to patients who have higher risk disease in earlier stages. So patients who have a thicker primary melanoma, a melanoma that's over 4 millimeters thick, melanoma that involves lymph nodes or stage 3 melanoma, we often give therapy, adjuvant therapy, after we do the surgery. And that can take the form of immunotherapy, which we'll talk about in some of our new approaches. We wanted to make sure the audience understands this concept of earlier disease and adjuvant, because as we talk about treatment for advanced disease today, these new therapies will be applied in the future to patients with earlier and earlier stages of disease. One point that we all wanted to make was that when we talk about melanoma, we talk about the thickness, which gives us information about the prognosis. There's a term that's also used called the Clark's level, and that's which layer of the skin the melanoma involves. There's something called a Clark's level 4, and that still is an earlier stage of melanoma and just involves the 4th layer of the skin. That's not stage 4 melanoma. So we just want to make sure that our audience today understands the difference between early stage melanoma, stage 1, stage 2, and stage 3, and our comments will really focus on stage 4.
So you've all had patients who've come in a panic because they think they're stage 4, they're actually Clark's level 4.
That's right.
That little word makes a
Right.
big difference.
Or if patients say they have metastatic melanoma in a lymph node, they think that's also metastatic or stage 4 disease. So our focus today is really going to be on systemic treatment,
Audio
treating the whole
recording for
body.
this meeting
But we also
has begun.
do surgery frequently, as I mentioned, for earlier stages of disease and sometimes for more advanced disease. We may get time to talk more about radiation therapy for certain metastatic sites and something called limb perfusion if somebody had melanoma extensively involved in an extremity. We may have time to talk about that today.
Okay. And just very quickly, sometimes people have multiple tumors that show up on the skin around the primary site. Is that managed differently from when the tumors may have spread to other organs, the brain or the liver?
Yeah, so that's considered in-transit disease, and that's considered still stage 3 melanoma. And we would either treat that with additional surgery or sometime actually perfusing the limb with treatment. So we still consider that as regional disease and still potentially curable.
Perfect. Thank you very much. And you talk about systemic disease and treating the whole body. And Dr. Atkins, if you could talk a little bit about one of the approaches, which is, we mentioned earlier, immunotherapy, getting the immune system re-engaged. And there's some drugs on the market now that use this approach, right?
Yes, Tim. So the purpose of immune therapy is not to directly target the tumor, but to activate the body's immune system to seek out and destroy cancer cells. The initial immunotherapies that were developed took advantage of the identification of the type of proteins in the body that were actually responsible for activating the immune system and administered them at industrial strength doses to try to superactivate the immune system. The first of those is a compound called interferon, which was initially discovered as something that was the body made when you had a viral infection that helped to eliminate the virus. And giving high doses of interferon, which is now the approved therapy since 1995 for patients at high risk of recurrence, was shown to prevent recurrence of melanoma in a small fraction of patients at risk, and also to prevent death from melanoma in anywhere from 5 to 20% of patients who were at risk for recurrence. So this is a standard therapy that has been used for close to 15 to 18 years, but has some problems. It needs to be given for a year. It has a lot of side effects, which are not surprisingly flu-like type of side effects that are problematic for the patient, and it doesn't work well enough. It only helps a fraction of the patient. So there is a need for better immune therapies, and it's our hope that some of the new things we'll talk about later in this discussion can fill that void. The next immune therapy that was developed was something called Interleukin-2, which is a protein that directly activates the cellular immunity, the cells of the immune system that recognize tumors. And Interleukin-2 was shown, when given at high doses, to be able to make tumor cells go away in patients with advanced melanoma in about 10% of patients, and patients where the disease went away and stayed away for 2 or more years likely were cured, and many of those early patients who were treated in the late 1980s, 1990s, when Interleukin-2 was just being developed, are still alive today. The problem with Interleukin-2 is it's has a lot of diffuse effects on the immune system. It causes a lot of activation of the immune system in a non-specific way, produces a lot of side effects, is required to be administered in an inpatient setting, and is only applicable to patients who have good organ function, who have access to centers that have a lot of experience in using that therapy. New research in understanding tumor immunology has identified that the immune system has specific checkpoints that help shut off the immune system when it gets activated, so it doesn't go haywire and destroy the whole body in response to viral infection. And one of those critical checkpoints is something called CTLA4. And it turns out that if you give a drug called ipilimumab, which blocks that checkpoint, it has the function of taking the brakes off the immune system, allowing the immune system to now be more powerful. And giving a drug like ipilimumab intravenously every 3 weeks for 4 doses has been shown to reactivate the immune system against melanoma in some patients, with about 10 to 20% of patients having disease control that lasts more than 2 to 3 years, and likely may be permanent in those. So having that type of checkpoint inhibitor creates a more tolerable way of potentially activating the immune system. The trouble is that it can also activate the immune system against normal cells, and some of the side effects include colitis or hepatitis or skin rash, and it requires some skill to be able to administer this treatment safely. So not all oncologists are comfortable using it, and people who are interested in using this treatment, you'll probably see an oncologist who has experience and is comfortable doing it. It's hoped that this type of checkpoint inhibitor will also potentially have a role in the adjuvant setting, and there are studies that are open now, clinical trials that are comparing ipilimumab treatment to the standard high-dose interferon for patients at risk of recurrence.
So the immune system's like a car at a stoplight with the accelerator's not on and the brakes are on. The IL-2 pushes the accelerator on, the ipilimumab takes the brakes off, and one or both of those may get things moving again, but you don't want to go too fast or you cause other problems.
That's correct.
Sorry, it's a very mundane way of expressing it, but
that's correct.
But it's fascinating that you impact one thing and it changes something else. Another way of systemic therapy, Dr. Pavlick, is to actually go into the cell and try to shut off the part of the cell that's running out of control, what we call targeted therapy. And I wonder if you could tell us a little bit about the targeted therapy drug that is on the market and how that's being used.
Yeah, targeted therapies have become a mainstay for many of our patients because we know that there are pathways that cancer cells, particularly melanoma cells, use in order to grow and metastasize. And many of these pathways get turned on, and when the signal gets turned on, the cancer just continues to grow, and we have no way of shutting it off. Well, we've been smart enough, fortunately through research, to be able to identify drugs that will shut off these turned on pathways and subsequently control the melanoma. And many patients, look at us and say, well, what are those pathways? And we use lots of letters to describe those pathways, so sometimes they are confusing, but the most common pathway that's abnormal in melanoma is what's called a BRAF pathway, so it's BRAF. And that is found in 50% of patients who have melanoma that goes to other parts of the body or advanced melanoma.
And that's a very high percentage for a mutation in cancer, right?
It is, and this is why we've been able to exploit these drugs so nicely, is because 50% of those patients will receive benefit. Not to ignore the other 50%, because we're still doing research looking at different pathways to maybe help those patients who don't have those mutations. But patients who have the BRAF pathway mutation, it's important to also understand that these are genetic mutations or alterations that occur within the tumor cells. These are not genetic mutations that a patient can transmit to their family, their children, because that's a question I get many times, is should I have my family checked? Is this a problem? And the answer is no. This is just an alteration that occurs within the tumor that now allows us to target that tumor with a specific type of treatment. The treatment that's most commonly used for BRAF mutations is a drug that was FDA approved in 2011 called vemurafenib. Vemurafenib targets the BRAF mutation, shuts off that signal for growth, and the cancer will shrink up. More than 50% of patients will also respond to the drug, so again, it's a very high response rate, and patients do very well with this drug. It is a pill form, which makes it very convenient for patients also. They have to take the pills twice a day. The downside to this therapy, however, is that many patients, after a prolonged period of time, usually within the course of that first year of being on vemurafenib, their tumors will develop a resistance to the therapy. And so their tumors will start to grow even though they're taking the vemurafenib. And so this is where our research is leading us now, is to combining many targets and trying to block pathways in more than one way to get better control of their melanoma. To divert a little bit away from BRAF, I think it's also important that patients know about a Secant mutation. These are mutations that only happen about 20% of the time, but it's in patients who get melanoma either under their fingernails, on their palms and soles, and sometimes in areas that are lined with mucosa, such as the sinuses and other parts of the body. And we know that if you have a Secant mutation, again, it's the Secant that stays turned on and drives those cells. If you give a drug called imatinib, it will also get the melanoma under control. And again, we're looking at better ways to get that under control, looking at combining multiple targets. And really the future of melanoma therapy is really going to be combining therapies.
So what I hear about the targeted therapy is that you get some dramatic responses. I mean, some of the stories you hear about people on vemurafenib is that tumors all over their body and they just go away. Now, we could just find a way to figure out how to keep that lasting longer.
Right.
It makes a better solution. So these are the drugs that are on the market now, and we had 2 drugs approved in 1 year in 2011 after 13 years of nothing being approved. And yet what I hear when I talk to people like you who are in the clinical setting and developing things is that the future is even more exciting than what's happened in the past few years. A lot of new things down the pipeline. And we're hearing, Dr. Atkins, a lot of things about some new immunotherapy approaches, particularly PD-1, PD-L1, TIL, all of these things. Can you help us think through this a little bit?
Sure, Tim. This is really an exciting time for immune therapy. And let me just set the stage a little bit. We've learned that in addition to these driver mutations like BRAF or c-KIT that are in tumor cells, that melanomas in particular have a lot of what we call passenger mutations, which are just damage to the protein, to the genetic material in the tumor cell that causes abnormal proteins to be presented on the surface. And these proteins can be recognized by the immune system. And immune cells can recognize them, travel to the tumor, get inside the tumor. But what we've learned is that when they get there, they hit barbed wire, which is things that the tumor does to try to shut those cells off from actually killing the tumor. And one of the things that is the tumor does is express a molecule called PD-L1, which serves as barbed wire, and if it sees an activated immune cell nearby, it shuts it off. So one way around this that has been used at some research centers around the country is to take those immune cells out of the tumor, take the tumor out of the body, take the immune cells out of the tumor, grow them up, identify the ones that are most effective at recognizing the tumor, and give them back to the patient in very high doses to see whether it can overcome those barriers within the tumor. And that's called TIL therapy. Okay. And that's a very complicated, labor-intensive treatment that's personalized for the patient and therefore hard to broadly apply. Another approach which really has us excited is to try to block the PD-L1, PD-1 interaction within the tumor cell and allow those immune cells that are already there recognizing the tumor to do their job. And there are now multiple antibodies that can do that, and they're being developed by multiple companies, and the preliminary data is really exciting. It appears that as many as half of the patients may see shrinkage of their tumors, and that shrinkage may last even when the therapy stops. And the side effects, because it's blocking a process that's happening only in the tumor, appear to be a lot less than seen with drugs like ipilimumab that act more centrally for the whole body, or these high-dose cytokines that stimulate the immune system everywhere.
So you have, I just want to make sure I'm clear here. So you have on the tumor cell, you have the PD-L1, and then on the immune system cell, you have the PD-1, and those two have to interact in order for the cell to hide from the immune system. And by blocking one of those or both of those, all of a sudden it's exposed to the immune system again. Is that the theory, or did I get that close enough?
That's close enough. There are multiple factors besides
Right.
PD-L1 expression that are there to shut off the immune system at the site of the tumor. But blocking the interaction between PD-1 on the immune cell and
I see.
PD-L1 on the tumor allows the immune system's function to be
To
restored.
re-engage. Okay.
So another approach that's been used for years has been vaccination, trying to induce an immune response against the tumor. And literally hundreds of trials have been used over a period of the last 20 or 30 years. And some of these vaccines failed because they were creating immunity against something that wasn't expressed on the tumor, or some of those cells could never get to the tumor, or when the cells got to the tumor, they were shut off by things like PD-L1. Okay. So the hope is that with a little bit of extra knowledge and being able to block those shutoffs, we may be able to investigate some of those immune vaccines and allow them to be more functional.
So one of the advantages of the immunotherapy approach, if I understand it, is that it's available to anybody, whether you have the BRAF mutation or the Secant mutation. That's not really relevant necessarily for the ability for these immunotherapy approaches to work.
That's correct. There are clearly reasons why some patients respond to immune therapy and others don't, and that's a subject of intense research. It appears that having immune cells in your tumor is a prerequisite to benefiting from immune therapy, but we don't know whether there are ways by combining certain therapies, either with these therapies with a vaccine or maybe with a targeted therapy, that we can induce immune cells to go into the tumor that weren't there before, and therefore expand the applicability of these novel immune therapies.
Okay. So you mentioned combining things, and Dr. Schuchter, this is something that you've spoken about a lot, and I know both Dr. Atkins and Dr. Pavlick, you have as well, but we're hearing a lot about combining drugs together. We talk about the accelerator and the brake on the immune system, or we talk about these patients who become resistant, the tumors that become resistant to the targeted therapy. Talk to us a little bit about what's happening in the combination therapy world and some of these approaches.
Sure. So what we've talked about so far are new drugs that have been approved for the treatment of patients with stage 4 melanoma. So Dr. Pavlick talked about the new BRAF targeted therapies, vemurafenib. Dr. Atkins talked about the new immunotherapies such as ipilimumab, we say IPI for short.
Right.
And the obvious question that both physicians, researchers, and our patients are saying, what about combining the two treatments together? So it is a very exciting idea to combine both immunotherapy and targeted therapy. And so there are ongoing trials that are exploring a number of combinations. To take a step back, how does a patient find out if their tumor has a broken BRAF gene or a broken Secant gene? This is actually a pretty easy test. When somebody has a tumor, has their melanoma diagnosed, and the tissue has been removed, the pathologist extracts DNA and can run a BRAF test or a Secant test. And now newer studies actually being done at many institutions that can sample 50 genes in a very simple sample, and that is going to pave the way for thinking about even newer approaches.
And I'm sorry to interrupt you, but this is, I think, a very important point. Should it be standard of care that anyone who is diagnosed, particularly with metastatic melanoma, have their tumor evaluated for these mutations?
Yeah, so a patient with stage 4 melanoma, we should know if that patient has a BRAF mutation or not,
Okay.
because that really tells us about what pathway, no pun intended, we're going to take. So
Right,
if a patient
right.
has a broken BRAF gene mutated, then we are going to consider using a medicine that targets the BRAF pathway. Knowing features about the patient, where on the body did the melanoma start, their age, gives us a clue. What did it look like under the microscope? Gives us a clue. Is something more likely to have a BRAF mutation, a Secant mutation, or something else? Younger patients, particularly with melanoma not in heavily sun-exposed areas, are more likely to have a BRAF mutation. Older patients, particularly with melanoma on the face, back of the hand, something called a lentigo, malignant melanoma, more likely to have a Secant mutation. But important, yes, that we understand if a patient has a broken BRAF gene or other genes, because there are effective therapies. So as we were talking about, really exciting to combine immunotherapy with targeted therapy. There are ongoing trials that combine vemurafenib with ipilimumab. There's interest in combining PD-1 antibody with new targeted therapies. Dr. Pavlick mentioned combining BRAF inhibitors with other targeted agents, so something called a BRAF inhibitor plus a MEK inhibitor. We'll come back to that. And there's really interesting data about combining ipilimumab with radiation treatment. There are some ongoing studies looking at the combination. And the idea is that perhaps if you radiate a tumor, we destroy or kill some melanoma cells. They release antigen or peptides, things that Dr. Atkins was talking about that are on melanoma. And that may trigger the immune response in a more significant way. So the IPI takes the brakes off, really allows for a fuller immune response. And by radiating, maybe you could steer that immune response to the melanoma cell. So this is really important area for the next step. So how do we combine these agents? What's the right combination? Is it sequentially that we give these agents, an ipilimumab followed by a targeted agent? Do we think about clinical trials? I do want to mention that the Melanoma Research Foundation has a new breakthrough consortium. This is a group of melanoma centers across the United States, the MRFBC. And the purpose of this consortium, which you know a lot about, is to allow centers to more easily combine these therapies. So sometimes there's different pharmaceutical companies that are developing the drug. Sometimes it can be a little bit tricky to combine two agents. And the idea behind the MRFBC is to really, in a rapid way, bring combination therapies to the melanoma centers across the country and speed up the pace of development. I mean, these are really exciting times, very exciting results, and we want to answer these many, many questions in a more rapid way. And I think the MRFBC is really poised to answer some important clinical trials and treat patients in a uniform way. You know, we thought of melanoma as one disease. You were diagnosed with melanoma, this is how we would treat somebody. But now we really understand that melanoma is multiple diseases. Some patient may have a BRAF mutation, somebody may have an NRAS mutation. There's going to be different features about the immune system. So it's more than one disease, and it is going to require multiple centers to come together to enroll on these patients so we have sufficient numbers of patients to answer these really important questions.
So you've all mentioned clinical trials. So let's talk just a little bit about clinical trials. I think a lot of patients, they hear clinical trials, they think they're going to be a guinea pig, they're afraid they're going to get a placebo and their cancer will be running rampant while they're not getting any treatment or any drugs at all. And yet it seems to me from what I'm hearing, clinical trials are critical to moving the field forward and having better treatments. Can you talk a little bit about that?
Yeah, we'd all love to talk about this because this is, we would say, the first choice for a patient who has advanced melanoma is to enroll in a clinical trial. All the advances that we've made and some of the most exciting drugs we can only get for our patients through a clinical trial. So a clinical trial doesn't mean that there's a placebo or a sugar pill involved. Some studies may have that, but for patients with advanced disease, you're definitely going to get an active treatment. And some of our most exciting combinations, the only way we can get access to that new drug is to participate in a clinical trial. It's also important to know that most insurance companies provide for the routine care cost associated with a clinical trial. So if patients have to have CAT scans or a physical exam, usually their insurance company or Medicare provides that cost. But this is a very important topic, and we all need to stay vigilant on making sure that insurers pay for these routine care costs, because this sometimes is actually less expensive than the standard of care, and the only way that we're going to make important advances is through participation in clinical trials. So the drug is often provided free, and some of the study-specific parts are provided by the sponsor or the pharmaceutical company, but the regular care is usually covered by insurance companies.
So I understand that in order for the field to progress and for us to have better answers and better solutions, clinical trials are critically important. I think a patient, while the patients care about the field, they really care about what's going to give them the best chance to live longer and better. And I heard you say that the first option is to go into a clinical trial. I'm wondering, Dr. Pavlick, if you could speak a little bit about this. From a patient perspective, is clinical trial in melanoma right now the best chance that they have, or one of the best chances they have for living longer and better?
I truly believe that it is the best treatment option for patients, because many of our clinical trials that we're going to talk to patients about actually are building blocks upon the agents that we talked about. And so they either include a BRAF inhibitor, they include some type of immunotherapy. They are access, like Lynn said, to drugs that we think are the future of melanoma that we just can't provide them with unless they participate in research. Right. And the other way I like to talk to patients too is that this is an opportunity for you to have a drug that we would never be able to get you in another circumstance. And even if we do the research and the drug looks very promising, it takes months to years to get that drug on the market. So this is an opportunity for you to get a groundbreaking therapy. We can always keep the standard therapies. I like to tell them we keep them in our back pocket. So this way, if in fact we ever need them, we have them. But they help move the field forward by helping us to learn more about how to better control their melanoma.
And we have a lot of clinical trials in the targeted therapy field these days, right? I mean, we talked about half of people have the BRAF mutation, half don't, but there's a lot going on in this field.
There's a lot going on in melanoma in general. I think there's just as many clinical trials out there for patients who don't have BRAF mutations. The MRFBC is sponsoring a BRAF trial where patients would be getting vemurafenib with a PI3 kinase inhibitor, another target that we know helps to shut off those abnormal pathways. And we hope that that combination would provide patients with better control of their disease. On the converse, there are many trials that are going on with immunotherapies like PD-1, ipilimumab, in combination either with targets or with other immunotherapies like radiation, like vaccines, things that we can better steer the immune system toward in conjunction with a systemic immunotherapy. And so really, whether you have a BRAF mutation or you don't, clinical trials are certainly something that you need to be able to go to your physician with and say, hey, what's available to me?
So if you don't have the BRAF mutation, you've mentioned the vemurafenib with the PI3 kinase, which would be a BRAF blocker, but there are other things. I hear NRAS, I hear AKT, I mean, all these other kind of alphabet soup things that are out there for the targeted therapy approaches.
Well, many times, many of the melanoma centers are looking at patients' tumors and looking for NRAS, c-KIT, and BRAF, because those are the things that we have drugs for right now. And so there are trials that are targeting patients who have an NRAS mutation, which is much, much less frequent than a BRAF mutation or a c-KIT mutation. We're also looking at other targets that may be non-specific, and those would be for patients who have no BRAF mutation.
Okay. So a lot of things going on in a lot of different fields. We haven't touched, and maybe we can do this very quickly. There are a number of different kinds of melanoma as we've described. There are some rarer kinds that involve the eye, involve the mucosal membranes. So there's mucosal melanoma, there's ocular melanoma, there's acral melanoma that shows up under the fingernails and toenails and things like that. These all have different mutations as well. And are we seeing progress in those fields too, or what is the status of that? Dr. Atkins, maybe you could speak to that a little bit.
Sure. Well, we're seeing progress in identifying what is driving some of those tumors, or sometimes in the case of ocular melanoma, the majority of those tumors. But it's not always possible, once you identify what's driving the tumor, to develop a drug that can inhibit the pathway. And so, at least with ocular melanoma, it's proving a little more complicated. We have to go to some more sophisticated drug development approaches, or to find other points further down in the pathway that could be blocked in order to produce benefit. But we know that these are different types of melanomas, and even though they have some similarities under the microscope, genetically they have different pathways that are activated and will require different therapies, and we need to do a lot of research to help to define what's the best treatment for those type of tumors.
And remember, BRAF gene, broken BRAF gene in melanoma, was described in 2002. It took 10 years approximately to get vemurafenib approved that targets BRAF. We don't think going forward it's going to take 10 years to develop new drugs for these other diseases and types of melanoma you just described. We really want to shorten that time period. But doing the testing now and really understanding that uveal or ocular melanoma, melanoma of the eye, is different than skin melanoma, and understanding the different genes that drive it, that kind of research is what lays the foundation for developing new therapies. So there are a lot of clues right now, that certain types of broken genes in ocular melanoma, maybe a MEK inhibitor might be useful. But having the basic research and understanding what's broken will lead to these next steps. Sometimes the patient or the public doesn't always understand, how does basic research help me, the patient? But what we see now is much easier understanding of what's broken in a cancer and more rapid application of these new drugs. Drugs that may be in clinical trials for other diseases that we can now apply in melanoma as we understand these different genetic profiles of cancer.
So I'm listening to all of this, and we're talking about approved therapies, interferon, IL-2, ipilimumab, we're the approved targeted therapies. We're looking at clinical trials of individual therapies and combination therapies. So a patient walks into your office, and they have metastatic melanoma. How do you plan out what the treatment course is for that patient? Which one starts on ipilimumab, and which one starts on a clinical trial of a vemurafenib and PI3 kinase? How do you kind of figure this out? I'd love all of you to speak to this and hear your thinking.
Sure, I'll start. I'll briefly. I would first say that there's no one right answer, and that there are different approaches. And so I think that I don't want patients to be so worried that the next decision is, all or none for them. And that it really is a discussion with the oncologist about what the right next steps are. As we said, we would test a patient's tumor to see if they had a broken BRAF gene. So in a patient that has BRAF mutant melanoma, the question is, do you start with vemurafenib, or do you consider starting with immunotherapy? And many of us, and I'm interested in hearing what you all say, depends upon how much symptoms a patient has related to their melanoma, what is the extent of the disease. The ipilimumab is over with in 12 weeks. If you consider vemurafenib, it's a pill, usually 4 pills twice a day that's given continuously. So if someone doesn't have very much disease and has relatively few symptoms, we may consider doing ipilimumab. We might consider watching if it's been very slow disease to change. So one could consider ipilimumab followed by vemurafenib, depending upon the response to the treatment. And we would look at what clinical trials we have available. Some clinical trials don't allow prior treatment, and so that's a factor as well. If a patient does not have mutated BRAF gene, then my approach would be to start with immunotherapy, look for a clinical trial. You know, Dr. Atkins mentioned the PD-1, which looks really interesting and may have much fewer side effects than ipilimumab in terms of this autoimmune side effect that we see. So it really is individualized, understanding a patient's symptoms, the extent of their disease, their age, other health issues. So that's sort of my quick summary about how I would handle. Curious, Mike, what you would say?
So there's no magic roadmap, right? Is that what?
So my approach in dealing with patients is always to look at curative therapies first, even if they have a lot of side effects. And right now, although there's much excitement about the targeted therapies, they are not curative. They delay the progression of disease, and they have people live longer. But at the moment, everybody is eventually having their disease recur, and the treatment for them once their disease recurs is undefined. The immune therapies offer the potential for cure. It may be only a minority of patients in the 10 to 15% range, but for those patients, it's like hitting the lottery. And if they look like someone who has slow enough progressing disease or limited enough symptoms from their disease that they have a long enough runway to be able to have a chance at immune therapy, whether that's with Interleukin-2, ipilimumab, a new protocol that involves a PD-1 blocking agent, that would be my preferred approach, saving the molecularly targeted therapies for if the immunotherapy didn't work or after they've progressed on the immune therapy. And it appears those treatments seem to work as well after immune therapy as they do given initially. For patients who have BRAF wild-type disease, I think immune therapy is the starting place for most of us, and we're looking at ways in which we could potentially improve upon the current immune therapies with the PD-1 antibodies, as Lynn mentioned, as an example, but also potential combinations of immune therapies, combining with vaccines, combining PD-1 with ipilimumab, combining immune therapies with other antibodies, such as those that inhibit vascular endothelial growth factor, blood vessel creation, are all things that are very exciting and offer the potential for doing better than what we currently do.
So it sounds to me like the answer, Dr. Pavlick, that I'm hearing is, do you do immunotherapy first or targeted therapy first, or do you do them together? And the answer that I'm hearing is, it depends.
The answer is there is no right answer. It's totally patient dependent. I mean, I think my answer pretty much reflects exactly what Lynn and Mike have said, is that, you know, if I can offer someone immunotherapy first, just because they have a BRAF mutation doesn't mean it's a knee-jerk response just to give them vemurafenib or put them on a BRAF trial. A lot of thought goes into what we select first. Again, immunotherapy is looking as the potential cure for a patient, although I don't like to say the word cure. I tell everybody to go into long-term remission. And if they're a candidate to do that, that's where I would go first. But again, looking at the patient, how fast their tumors are growing, what's the extent of their disease, are they going to have the luxury of waiting about 8 weeks before you see any type of immunoresponse? It really plays, you have to look at all the factors to make that decision. And I really think it's a decision that gets made between the doctor and the patient, and because there is no right answer.
So one of the things that impresses me in hearing all of this is that when you go into treating metastatic melanoma, it's not as though you're saying, we're going to give you this drug, and that's our plan. That the first thing you do is the first step in a longer plan. I talked to one doctor who said he pulls out the the white paper that gets laid down on the exam table. He pulls that out and lays it all out and says, okay, here's step one. If that doesn't work, or if it quits working, we go to step two, and has like a whole roadmap of step after step after step. So when you go into a patient, you might say, here's the first step in talking with this patient. But in the back of your mind is, if this quits working, or if it doesn't work as well as we want, there's plan B, C, D, and more plans that are coming up as we go down the line.
Yeah, and one of the things that you realize is that you need to have backup plans. And sometimes starting with one approach may limit your options later. So it's very important for patients, when they get a diagnosis of advanced melanoma, I'm sure the tendency is to get treatment right away. But it's very important, much more important, to get a lot of opinions and make sure you start with the right treatment, not with the quickest treatment, because that may maximize your options later on.
So we're spilling over into our Q&A session because some of my questions are coming from things that have been submitted before. And I love the dialogue and the interaction here. One question that was asked by more than one person was, I've been diagnosed with melanoma, maybe late stage 3, stage 3B, or maybe it's a stage 4. Is my life over? I can't think about planning for what may happen 5 years or 10 years from now because I think I'm done. But I'm hearing a lot of hope from all of you. And yes, metastatic melanoma is a very serious cancer with serious challenges, and yet tremendous progress is being made.
Yeah, so what you mentioned is somebody with stage 3 melanoma. That means the patient had melanoma that traveled to a lymph node, has no signs of melanoma right now, but with a risk of recurrence. We are in an incredibly excited and hopeful time. I hate to say this, but we probably have 75 years of melanoma experience here, and we've been treating patients with melanoma for probably almost 25 years, each of us. We couldn't be this optimistic and talk about this long game plan of treatment options until the last several years. Now we really see therapies that are highly effective, that may not have very many side effects. So I would say it's a very optimistic future. The patient that wrote that comment should definitely plan for the future, but will require a team approach going forward. You know, the team of physicians taking care of somebody with melanoma is often a surgeon, a dermatologist, and a medical oncologist. But I would still say it's a very exciting and hopeful time with lots and lots of new discoveries, which is really exciting for us and for our patients as more and more treatments become available.
So,
And I was going to say, I think what's important too is that many of these now approved therapies for advanced melanoma are now being explored in the preventive setting or the adjuvant setting. So there are clinical trials out there for patients with stage 3 disease who may be able to participate in a trial with either a BRAF inhibitor or ipilimumab as, quote, preventive therapy. And we don't know whether these are going to make an impact on their disease, but we won't know until those trials are done. So we have to encourage patients to participate.
I think one of the hardest things for patients is to do nothing. So you're diagnosed with cancer, it scares you to death. Your mind is in a whirlwind, and you're thrown into this maelstrom, this kind of hive of activity where you're meeting the radiologist and the surgeon and the nurses and the whole treatment team and surrounded care, and then maybe the lymph nodes are taken out, or maybe just simple surgery, and then, okay, go on, and we'll keep an eye, and if anything else happens, we'll talk to you. And patients want to feel like they're doing something. Being passive is really hard. So you're saying there are more options now for people in that setting that are really in the clinical trial setting that will help push the understanding forward, but it may have an impact for that patient as well.
Sure, but I want to make the point that for a stage 3B melanoma patient, 50 to 60% of those patients are cured with their surgery. And with treatments, the standard treatments such as interferon, you might add another 10% to long-term remission. And for patients with earlier stages of disease, their outlook is even better than that. And even though we have all these new therapies, it might be that patients' prognosis is so good and the treatments, which aren't 100% effective, might be causing more problems or not be able to help them sufficiently if they already have a good prognosis. And what those patients need to do is to have a relationship with a physician or a team of physicians that they trust, to be followed regularly, and if they should be unlucky and have their disease come back, that it gets managed promptly and appropriately.
So I want to touch on something you just raised, because this came up in the questions we received as well. You said have good follow-up with a treatment team that you trust. People in the ordinary world don't know melanoma treatment teams. It's just, those aren't the kind of people, you know, we may know mechanics, we know plumbers, we may know our clergy. We don't have a melanoma treatment team in our back pocket just in case we have melanoma. And what I'm hearing still from patients is that a lot of doctors are prescribing some older approaches that don't reflect the newer advances, the new treatment approaches. I still hear patients who are told, gee, you have melanoma and nothing really works, go home and get your affairs in order. And at some point, for a lot of people, that's the right advice, but it seems that's not the first advice you should get. How can a patient know that their treatment team is giving them the approach? That what kind of due diligence can patients do? What kind of questions can they ask? Not to second guess the doctor, but just to make sure that they do have a good treatment team around them. It's a hard question, right?
Well, I think most melanoma patients, because it's not a very common disease that's treated in the community, like breast cancer, lung cancer, and colon cancer, I think patients owe it to themselves to seek a second opinion from a large melanoma center. It doesn't mean that they have to get their treatment there. It just means that you go and have the discussion, find out what's available, what are the options. Many times I will work with a community doctor where the patient says, you know, doc, it's just too far for me to come into New York. You know, I live near, you know, Jabib, and I can't afford to come in. So will you work with my doctor and give me ipilimumab or give me vemurafenib, or I can't participate in a clinical trial because, again, it's too much for me to come in. I'm older, I have limited resources, and many times we can work with the local docs to take care of these patients in the best way possible and not just default and say, yeah, you just get the old standard chemotherapy, because I really think that's just not fair to patients.
Well, I would add that, you know, these types of seminars and the MRF website has a lot of important information. And, you know, there's different parts of the treatment of a patient where it's important maybe to get another opinion. So after somebody's had their surgery and we know about whether or not they have lymph nodes involved, what is adjuvant therapy going to be? There's actually some controversy even amongst melanoma oncologists about what that treatment should be. So important to get, I think, seek expert opinion, particularly trying to get access to clinical trials, which are not always available in a community setting. And then in patients with stage 4 melanoma, at different points, you may have tried one therapy, it worked or stopped working, and then you want to think about the next step. That may be the time that you seek another opinion. I think the melanoma community works very well together, and we do work with our community oncologists who do a phenomenal job of trying to understand all these latest treatments. So that partnership with the community oncologist and the patient surgeon and the patient's dermatologist is really important. And we think that that's an important part of what we do, and to try to provide that counseling to our patients and their families.
So I want to, Dr. Atkins, go back to you for a second. We've talked a lot about the immune system, and we know that a lot of different things can impact our immune system. We had a number of questions about diet, exercise, nutrition. Should I take supplements that help boost the immune system? Should I, if I exercise, will it lower stress and that helps my, so the role about these kinds of other things in either enhancing the function of the therapy that you're on, or helping prevent recurrence. And you must get these questions from your patients.
Questions all the time, and patients are concerned and they want to be able to do something to help their treatment work better, and maybe they feel guilty about something that they did in the past that they think might have been responsible for them getting melanoma, even though it probably isn't. So there is not a lot of good clinical research that supports that diet, exercise, or nutrition can impact the outcome of a disease, but it's certainly good for the patient to exercise if they can, to eat a balanced meal. We tell them not to go to extremes, to suddenly change what they're doing in a major way, to torture themselves with new diets or new routines. It's hard enough to sort of deal with the cancer and the cancer treatments without adding some other things on top of it. But and furthermore, some of these approaches that you'll read about may actually interfere with the effectiveness of the treatments they're getting. From an immune standpoint, things like interferon or interleukin-2 or ipilimumab or the PD-1 blockers have been shown to critically enhance the immune function, far more than any change in diet or vitamin that you can do. And it's important to make sure they can work as well as possible by not having some other approach being taken that might interfere with their efficacy.
Do you have?
Do we have time?
Well, we can take a few more seconds.
Okay,
Go
no,
ahead,
I think
go ahead.
I totally agree with what Mike said. Patients do have a lot of questions about this. I would say that, like other cancers, in other cancers, there may be a greater link between diet and getting cancer or recurrence. We don't have that information in melanoma. There's a lot of discussion about vitamin D.
Yes.
And some question about whether low vitamin D levels could be associated with a risk of melanoma or associated with a risk of recurrence. That work is ongoing. I do sometimes check vitamin D levels. What we don't know is whether fixing a low vitamin D level has any impact. But we do obviously advise patients with melanoma to avoid excessive sun exposure, to use sunscreens. And there's a question about whether one would get lower vitamin D levels as you're trying to protect your skin. It really takes only a small amount of sun exposure per day to get good levels of vitamin D. The sun interacts with cells in the skin to develop and create vitamin D. So I think it's a really important question. I think exercise has been shown to be helpful in patients with lymphedema. That's new data that's emerged from the breast cancer literature. We used to tell patients don't exercise, but we know with axillary lymph node dissections and groin dissections, one of the complications is a swollen leg or lymphedema, and exercise is a good thing.
Okay.
So a really important question. I just think we don't have good recommendations about how to modify in terms of prevention.
I do want to highlight one thing, Dr. Atkins, that you said, that some supplements, some dietary supplements can actually interfere with the function of the treatment that you're receiving. So if you do take these kinds of supplements, if you do choose to make nutritional changes, it's critically important to tell your treatment team about that, is what I'm hearing from
That's correct.
doctors. Yeah.
Absolutely.
So I want to stop and just speak to our audience for just a second. We're at an hour, and yet we still have a lot of questions and answers in the queue. So our panel, we had a feeling this might be the case, has agreed to stick around for a little bit longer. We will keep the webinar going. If you need to sign off now, we'll try to have the questions and answers on the website later. If so, thank you very much for joining us for this, and we will have this on our website. We'll try to get to everyone's questions in the future. But we're going to take a little bit more time, keep the webinar going a little bit longer to try to get through a few more of these questions, if we may. And Dr. Pavlick, I'm going to ask you a really tricky one. I apologize in advance, but we hear a lot about melanoma and pregnancy. And sometimes it's, I've had melanoma in the past, and is it okay for me to get pregnant now, or will my melanoma come back? Or it's, I got pregnant during my pregnancy or just after I had a baby, I got melanoma. Is it because I was pregnant? So what I'm hearing from doctors when I talk to people is that, well, there's no data around this, and yet I hear a lot of anecdotal conversation. Do you have patients that talk to you about this, that have had melanoma, and should I get pregnant, should I not get pregnant, or do you have any?
Unfortunately, too many.
Too many, okay. So give us your insight on this.
It's again, a very difficult question to have to field from women, because these are women who are of childbearing age. They want to have families, either they have children or they want more children. And there's just really no good solid data out there that says, yes, go ahead and have more children. No, don't have any more children. I kind of have the Pavlick rules of thumb. I don't know if they're right. I don't know if they're wrong. I have many young women who have had melanoma in the past that are not associated with their pregnancy. And I don't think those women are at any particular increased risk if they want to go on and have children. Depending on their stage, I may ask them to wait a little bit so we can determine the natural course of their melanoma, if in fact it's going to recur or not. But in general, if a young person has had a melanoma that wasn't associated with their pregnancy, I'm usually not too crazy about telling them not to. Where I do get a little crazy is when a woman comes in and says to me, I had this thing, and once I got pregnant, it started to grow like wildfire. Right. And I went to the doctor, and they did a biopsy, and it was melanoma. I think those are a little bit different in the situation. So I think, can we say that those hormones stimulated or drove that melanoma? In my case, yeah, I think that's kind of what I believe. And for those women who get melanomas while they're pregnant, we try to either get them to term, depending on when they're diagnosed. If it's very early on in the pregnancy, many times we'll have them, consider aborting the pregnancy at that point. But usually my rule of thumb is I would be very, very hesitant to want to have them get pregnant a second time, knowing how rapidly this grew while they were pregnant the first time.
So this kind of spills over into another area. I think when someone is diagnosed with cancer, your first question, I mean, just to be very blunt, is this going to kill me? Am I going to die? But then once you get past that, or once you've kind of begun to deal with that question, there are other questions that arise. One is, if we deal with this now, will it recur? We've talked a little bit about recurrence. We may want to spend a little more time on that in the future. But the other question is, how does this affect my children, my family? Are they at elevated risk? And we talked about the genetic testing for the tumor, looking for BRAF mutation. And Dr. Pavlick, you were very good at explaining that the mutations in your tumor are not inherited genetic mutations that get passed down to your children. But some people still do genetic testing that might relate to their children. People with melanoma worry, are their children at elevated risk? I'm wondering if you could speak to that.
So sometimes melanoma can run in families. So there is something called hereditary melanoma. And the family situation is that multiple relatives have melanoma, an uncle, a parent, a cousin. They may have other types of tumors such as cancer of the pancreas. So there is a type of hereditary melanoma. Sometimes it's associated with funny-looking moles, and there is a specific gene called a germline mutation that's associated with hereditary melanoma called P16. It's also known as CDKN2A. There is a test for that, but at the moment we don't recommend testing generally, unless it's really going to change the management of how we monitor somebody. So there is such a thing as hereditary melanoma. It's rare. About 10% of the time, hereditary melanoma is related to this P16 gene. There are other genes that can be linked to familial or hereditary melanoma. The breast cancer gene, BRCA2, can be associated with melanoma, and there are a few others. So most of the time, there is no significant risk to children, but we do say that if someone's had a melanoma, to make sure that they let their physicians, the children and siblings, know that someone in the family's had melanoma. Maybe a good idea to get a skin exam, because part of the risk for melanoma is really about coloring. Someone have blonde hair, blue eyes, red hair, that is inherited, not so much a gene that's broken, but someone may be at higher risk for developing melanoma. So we do counsel family members should be checked, possibly by a dermatologist, should let their physicians know about a family history of melanoma, and they may need to be followed by a dermatologist. And everybody, we would recommend safe sun practices, looking at their skin and avoiding excessive sun exposure.
So my mother and her twin brother both had melanoma. And I've always heard that the number one risk factor for melanoma is having a first-degree relative, a direct blood relative who's had melanoma. But if I'm hearing you right, then that may not be an inherited genetic trait per se, so much as it is a broader trait of skin coloration, hair color that elevates the risk.
Right, but you described two people with
Twins.
yeah, so, that would be a family that we would say, possibly, not necessarily that you need to be tested, but that you need to be cautious. You definitely need to see a dermatologist and have regular surveillance, and you can have the conversation about whether or not to do genetic testing. I would also say that people say in their family, oh, they had skin cancer, and they think that that maybe was a history of melanoma. So we really want to distinguish that there are three types of skin cancer, basal cell and squamous cell, which are really common, not serious, easily treated, and then there's melanoma. And what we want to know about is a family history of melanoma, not just about skin cancers. And I think important to really push, are there other cancers in the family? Because there are other cancer syndromes that are linked to different types of cancer. So important that you know your family history about other cancers. Share your information about melanoma with your family so that you can gather a really complete family history of cancer.
So this spills over into another question. Dr. Atkins, I'll let you take this one, and that is, we had several questions about the linkage between melanoma and other diseases, Parkinson's, other kinds of cancer. Do you have any thing to share on this?
Well, Lynn just mentioned that P16 mutations in the germline are associated with other cancers, such as pancreatic cancer. There's also, not infrequently, patients who are getting CAT scans because of a history of melanoma that might have some other type of tumor picked up incidentally from CAT scan. And commonly that might be a small tumor in the kidney or small nodule in the lung that might not have been picked up and might actually be a lung cancer rather than a metastasis from melanoma to the lung. Sometimes we see lymph nodes that are enlarged on CAT scans in patients who are being screened for risk of recurrence of melanoma, and it turns out to be inflammatory disease called sarcoid. So it's very important in someone who has not been documented to have disease recurrence already from a melanoma that some sort of formal documentation with a biopsy of the first sign of recurrence actually take place so that people don't get treated for metastatic advanced melanoma when they don't actually have it.
Right. So you mentioned CAT scans and that, again, everything's connected, right? So Dr. Pavlick, we had a question about PET scans. So CAT scans given routinely, PET scans also are given sometimes, but I hear of patients whose insurance companies won't cover the cost of PET scans, that PET scans are given sometimes, but not always. What does a PET scan do that other scans don't do? When should it or should it not be used?
Well, I think you've again given me another very controversial question.
Yes.
Thank you. CAT scans are really scans that give you good three-dimensional pictures of the internal architecture of your body. What a CAT scan, PET scan, the combination PET-CT does is it will give you those architectural pictures to a limited degree, but then it gives you what's called radioactive FDG, which is fluorodioxyglucose, or radioactive sugar, because the thought is that cancer, infection, or inflammation, and again, PET scans are not always definitive of cancer, are rapidly metabolizing sugar. And so you give the patient radioactive sugar, you let them sit for a while, then you put them on the scan table and you look for areas in the body that actively take up this sugar. Does it add anything? I'm not convinced that it does. I think many times if you see something that lights up, now you're committed to go after it. And I would venture to say that many times we go after it and we find out that it turns out to be nothing, but it induces some extra anxiety for those patients. You know, I think when a patient has in-transit disease or satellites that are big lymph nodes or something that's going on an extremity where it's not caught on a CAT scan, that may be helpful to know, is there just one in-transit metastasis and is it worth going to surgery for, or are there many others that are below that where now you want to think of something like a limb perfusion and not going to surgery. So I think there are circumstances that you clearly advocate doing a PET scan for, but in general, I've become more accustomed to doing CAT scans, and I think insurance companies are now also getting onto that bandwagon of we'd rather pay for CAT scans than PET scans, and it also exposes patients to less radiation.
So I just want to add that I'm not a fan of PET scans as a screening tool to look for distant metastases. There are too many false positives, and you may find things that may represent melanoma, but if you can't see them with the CT imaging, you can't do anything about it. So it's a non-actionable finding that just makes everybody anxious. But where I agree with Anna, they can be very useful in helping to identify whether a mass that's picked up on CT scan or physical exam actually represents cancer or something that's benign, or if you're planning a surgery, just to make sure there aren't other areas in the body that would make the surgery less useful to remove a mass when there already is distant disease in other places.
So the setting where we're thinking about doing scans, patients who have stage 3 melanoma have no evidence of disease, we're monitoring for a recurrence of the original melanoma. And so that monitoring is with usually blood tests, physical examination, and scans. And roughly speaking, we do those scans every 6 months or so, sometimes 9 months, up until about 5 years. And it's either CT scans or PET scans, and I completely agree with the comments that have been made. So patients shouldn't go, this is not a situation where you gotta go crazy that your insurance said no to a PET scan and they're willing to pay for a CT scan. I mean, there are a lot of things that we need to advocate for, but pushing an insurance for a screening to look for recurrence of a melanoma, I don't think, I mean, CT scan or PET, is a huge difference in the cost. And as has been mentioned, a lot of what we call false positives.
And you would say that's true even if a person is at higher risk of recurrence, if they have ulcerated deep initial tumor, you would still hold to the CAT scan versus PET scan in most of those cases or all of those cases?
Yeah, I think scans should be done, and I think there can be a lot of discussion about whether it's a PET or CT. Sometimes I've alternated, but I would agree that I'm using less PET scans now than I was even using 5 years ago.
And I just want to qualify that. I'm not even sure there's solid evidence that CT scans are useful. Yeah. I think data seems to indicate that most recurrences are picked up by a good history and physical exam. That covers about 80% of the recurrences. And you can use patient coming in with new symptoms or a physical finding as a trigger for doing a CAT scan. And in that case, what you're going to find is more likely to be a true positive than a false positive. We tend to use chest x-rays maybe once a year as a way of examining the lungs to help identify whether we're going to get a CAT scan or not. And that's a lot easier thing that the patient can have at the time they come to a clinic visit. And we occasionally order blood tests that, like a simple blood count that may detect for bleeding, blood loss in the GI tract, which is a way melanoma can sometimes present that gets picked up late, or an LDH, which can pick up for rapidly dividing cells in the body, although it's also not specific, but you'd want to know about it, and that might trigger doing a CAT scan. And when we've compared our results to those at other centers that use CAT scans, there's really no difference in how quickly we're able to pick up recurrences and be able to get patients to these new therapies without having them feel like they're going to be picked up late and miss an opportunity to potentially get the right therapy for them.
So you talk about scans. I'm mindful of a patient I talked to a year ago who diagnosed stage 3 A or B, I can't recall which, now 15 years after that diagnosis and still going in for scans. And And they were saying, how long do you do this? I mean, do you go 5 years? Do you go 10 years? Do you go 15 years? And at what point does the risk of the exposure to radiation become larger than the risk of recurrence at that far down the line? How do you make that determination?
The purpose of monitoring patients is twofold. One is risk of recurrence somewhere in their body, and also to try to detect a new melanoma. So patients who've had melanoma have about a 10% chance of getting a new melanoma on their skin. We used to do scans up to 10 years, but we don't do that anymore. Most recurrences occur within the first 2 to 3 years after diagnosis. So I think it's reasonable if you're going to do scans to do them up until 5 years, but I don't do scans any longer than 5 years. I would not do them this far out. Patient has a very high chance of being cured. The dermatology visit is sort of the key visit for that patient who's 15 years out to get a good skin exam.
So Tim, we actually did a study of this, and we looked at patients who hadn't recurred, and we did a CT scan and a head MRI on every one of those patients who hadn't recurred at 3 years. And in looking at 50 patients, we found that only 2 of them had some abnormality on their scan that turned out to be cancer. 6 had abnormalities, 4 of those were false positives, 2 of them turned out to be cancer, and in each of those cases, those patients had symptoms that would have prompted us to do a scan anyway.
Okay.
So our conclusion is that there's no value in scans, even for high-risk patients, after the 3-year time point, but there is value in still seeing the doctor to get a history, to get a careful physical exam, and also to see the dermatologist to look for new melanomas, just to keep those connections in place in case a new problem develops. It doesn't mean you can't recur. It's just that doing a random scan at some defined interval is not going to be what picks it up. It's going to be your relationship with your doctors and your ability to identify something that's changed and is abnormal that allows you to get on the phone, call your doctor's office and say, I need you to check this out.
So we have a question about brain metastasis I want to get to in just a second, but very quickly, we also had someone who wrote in, followed up a comment saying that you should be treated at you should get a second opinion at a place, I think, Dr. Pavlick, you mentioned this, at a place that sees a lot of melanomas, a good big melanoma center. And the question was very pragmatic. How do I know what those centers are? I know that on our website, melanoma.org, we have a list of people who see a lot of melanomas. I wouldn't claim that it was that comprehensive. We don't do a stamp of approval or anything like that. Any quick advice you could give to someone who says, I do want to get a second opinion, I want to make sure it's somewhere that sees a lot of melanoma, how do I figure that out?
Well, I think everybody, since they're watching this webinar, are internet savvy. And I think that's a good place to start. You know, most melanoma centers are located in academic teaching hospitals because that's where the research occurs. And so you want to look for an academic center. And my answer would be Google your local academic teaching institution and you will most likely find the closest melanoma center.
And look for, I would think, I don't know, maybe I'm wrong about this, but look for who does the melanoma work there. I've looked, for example, when someone wanted to know, is there a melanoma doctor in my community? And I would just look at a teaching hospital, look for melanoma, and the person who's listed as heading the melanoma program has their primary interest of something unrelated to melanoma. You know, they do 17 things, melanoma's one of them. That might not be the right place to go if they don't have a team that has a lot of melanoma expertise. Would that be correct, you think?
Well, and I think a lot of, on the academic websites for your institution, they also talk about the programs. So, you know, you will clearly say that there's a melanoma program that's a multidisciplinary program that includes the surgeon, the oncologist, the dermatologist. You want to look for that well-rounded team approach.
Okay, that's really, and that actually is a great segue into brain metastases, right? Because this is an issue that patients have, particularly with clinical trials. A lot of clinical trials don't allow you on if you have active brain metastases. How do you, I think there's very few things that are scarier than knowing that you have a tumor in your brain. I think that just viscerally, it's really scary. And yet, treating brain metastases, it may involve a systemic therapy, but it may involve a radiation oncologist, it may involve surgery. What are the options for dealing with brain metastases these days?
Well, the brain is a frequent site for melanoma to travel to. We don't completely understand why that happens for patients with melanoma, but once melanoma has metastasized and is stage 4 disease, it can involve the brain. We usually, symptoms may be a patient has a headache, maybe some confusion, maybe some part of their body is weak, or they notice some neurological symptom. And the best imaging is really an MRI of the brain to give us a sense for, is there involvement of the brain? And the treatment depends upon the location of the brain metastasis, what area in the brain, and then how many are present. So depending upon that, we may go with surgery to remove it, but if it's in a critical part of the body, in terms of speech or motor function, surgery may not be an option, but surgery is considered. We often use something called gamma knife or cyber knife, which is a way of giving very specific dose of radiation just to the brain metastasis and spare the rest of the normal brain. But if there are multiple brain lesions, then we often consider what we call whole brain radiation, radiating the whole brain. What's been really interesting is that some of our newer therapies actually travel to the brain. So there's very clear evidence that treatment with ipilimumab can result in brain lesions, brain metastasis shrinking. Vemurafenib can also be associated with a response in the brain. So we do a combination of both local management and then think about whether the patient's well enough to consider systemic treatment as well. There's a pill called temozolomide. It's a type of chemotherapy pill. It's FDA approved for brain tumors. It's not FDA approved for melanoma, but it does have some activity in melanoma, and we know that that chemotherapy pill gets to the brain. So sometimes we use the temozolomide, also known as Timodar, to treat brain metastasis. But again, a very personalized discussion with the patient and his or her family about how symptomatic the patient is and what are the overall goals, and then coming up with the right plan, which again, very often is a team approach.
So, Dr. Pavlick, why is it that a number of clinical trials don't allow you in if you have active brain metastasis?
Well, because it's very tough to predict whose brain metastases are going to be able to be easily controlled. And you have to understand that many of the brain metastases can be hemorrhagic, so they can spontaneously bleed, which leads to having to take the patient to surgery. It really does complicate your findings. There are some trials, however, that are specifically asking the question, can we treat brain metastases with systemic therapy and not give patients radiation? And so, again, just because you have brain metastases doesn't mean that you're not eligible for clinical trials. Some clinical trials may exclude you, but some clinical trials are out there looking for you.
So I've heard about this blood-brain barrier, that it's hard for some drugs to get into the brain because the body is good at keeping things out of the brain that could be harmful. Is that an issue, or?
Well, I think we used to think that was an issue, and that was one of the reasons why we thought that our patients who were sometimes responding in the rest of their body were failing in the brain, that the drugs weren't getting there well enough. And in truth, the brain is probably not that much harder to treat than other organs that are difficult to treat sometimes, such as the liver. And so we now are finding that now that we have active drugs, that we can actually treat the brain and get across the blood-brain barrier better than we had thought we would. The tumor cells got there. Hopefully our drugs and the immune system can also get there. And I think in summary, having brain metastases from melanoma used to be considered just an awful situation, but now we have so many tools available to manage those brain metastases that we're finding that patients with advanced melanoma are no longer dying just from their brain metastases, and that if we can control their systemic disease, we have a chance of having them have a long-term benefit from treatment.
That's a great piece of news. I mean, again, speaking to how things are changing, how things are moving, it strikes me in hearing all of this that patients need to take some initiative. If you're diagnosed with melanoma today, ask questions, look at what's out there. I know it's more work for you, right? Dr. Pavlick, we were talking before this session that people are coming in with printouts from the internet and things like that, and it makes more work for you. But it seems to me that now is the time for patients to really ask good questions and make sure they are getting into a good treatment team. And it can make a difference in outcomes.
Well, we all, I think I can speak for my colleagues here, we enjoy having patients who come in who are informed, who ask good questions, and allow us to help work out with them what the best treatment approach is for their particular situation.
And I think when you have a patient who understands the disease and understands why you're making certain recommendations, it makes treating them so much easier because they understand why you're telling them to do what you're telling them to do. And so I really, just like Lynn and Mike, I'm sure we make sure that patients really understand the disease as best they can, because the better educated they are, the easier our jobs are.
I'll make one quick comment, and then we're going to do one last question in the last minute or two. But I've always heard of people talking to their doctors and say, well, what would you recommend if this was your mother you were treating or your son? And one doctor told me about hearing that and said, I feel like saying, well, you mean if I really cared about you, what would I do? The fact is, the advice and the counsel you give to patients is exactly what you would want to have given to you or to your loved ones or things like that. And that's really comforting, I think, from patients to hear that they're in the hands of people who really genuinely care about their outcomes. So we touched briefly, and we had a couple more questions about this as follow-up, and if we could do this very quickly so we can let everyone go and you get back to taking care of patients, which is what we want you to be doing. The question again about what do you do when your cancer's all gone and now you're just waiting. And we talked about some people will take interferon to try to reduce their risk of recurrence. Some people will go into clinical trials. Do you have any other recommendations for someone to help them feel like they still have control of their life, that they're controlling their cancer, not their cancer controlling them, in this interim period, which hopefully will last for the rest of their life? But any last advice? How often should they be seeing their doctor? How often should they be scanned? Should they consider any other treatments?
Well, I would say that they should find a team of doctors who they trust and set up a follow-up regimen that's appropriate for their risk of recurrence, and to hope that those doctors will inform them of the type of things that they should be looking for that might be clues that they may be at risk for recurrence, and to be on the lookout for those things that sort of are problems that come and stay, and to contact their doctor if they have a problem that worries them, come in and be seen. And in the otherwise, I know it's easier to say than done, to go about their lives normally as possible, because if they let the cancer control their lives at the time when they have no visible cancer, then they're not, then they've added an extra problem to their life beyond the actual disease that they have.
Yeah, I agree. And many times it's a huge anxiety point for many patients who have high-risk disease. And we do talk to them about alternative ways to relieve the stress of this anxiety, either through support groups. We have a melanoma support group at our institution. We have yoga for patients. Looking at acupuncture, different ways to help them gain control of a situation that they really don't have control over. And putting it, like I like to say, they have to put it on the back burner, not forget about it, but keep it there, but they have to go on living because that's why they did what they did.
We find that for some people, they've been fighting melanoma in themselves personally. And if they can then segue into joining the broader fight against melanoma by becoming a phone buddy, a peer-to-peer counselor, by becoming a volunteer, by speaking in their local school or working on a piece of legislation that will help, that gives patients something to do that's active and involved and engaged and really helps the broader community. I can't tell you how wonderful this has been. I wish we could take like 4 hours, but this is been fantastic. We've covered a lot of different areas, and I couldn't ask for a better team. Dr. Pavlick, Dr. Atkins, Dr. Schuchter, thank you so much for being here today, and more broadly for what you're doing for patients, not only in providing outstanding treatment and care, but also in pushing the field forward and helping provide for new and better treatments and cures for the next generation of melanoma patients. Thank you very, very much. I'll say this on behalf of all the people who are watching, and to those of you who are watching, thank you for joining us today. I hope this has been helpful in giving you the tools you need to take control of your struggle and your fight. And we have a lot of resources on our website, melanoma.org. This webinar will be up on the website within the next few days. Give us a little bit of time to do the technical pieces. Any questions we didn't get to, we'll try to list those there and answer them as well. And please don't hesitate to reach out to us at the Melanoma Research Foundation or any of the other resources that are available for the melanoma community. We are absolutely convinced that patients who are well informed and well